Thank you everyone for joining us today for today's webinar. We have two great speakers from NextGen Healthcare, Christine DeFrancisco, who is the Senior Director of Managed Services with NextGen, and then Denise James, who's the Senior Manager of Managed Services with NextGen Healthcare. Thank you both for joining us. The topic today is strategies to streamline credentialing. And before we get started, I just want to run through a couple things. One, the webinar is recorded. So if you have to drop off or if you want to share it later with someone you find something useful and you want to revisit it, we will send this out in a couple days, a replay to everyone that registered, and you're more than welcome to share it with colleagues or anyone that you feel it's valuable to. Secondly, if you do have a question during the webinar, feel free to ask it down in the, there's two places where you could ask: the questions window in your webinar pop-up. You could ask it in the questions window or in the chat window. Either one, we'll be able to answer it. And we will do a Q&A at the end, and anything we don't have time to get answered today live, we will follow up directly with an email. And with all that being said, again, I'd like to welcome Christine and Denise, our guests today, and I'm going to turn it over to Christine.
Thank you so much, Chris, for the lovely introduction. Thank you all for joining us. We're going to try to wrap this up in about 20-25 minutes, so we don't take too much of your time, but we're going to start today with opening up to what market drivers are and how that could potentially impact your credentialing. And then I'm going to turn it over to Denise, who's going to go into detail on what exactly is credentialing and those nuances. And we're going to spend some time as well talking about keeping the patients you have, as well as diversifying to see the patients you may want to have. And then we also want to be able to offer you paths forward if you feel like you're struggling in this realm. And then we will leave some time at the end for questions. So to lead things off, I wanted to dive into, before we dive into the strategies of how to ensure you're getting paid for what you do, I want to open things up with where the market is today and how the market changes affect credentialing. One of the biggest trends I've seen recently is that providers are trying to get in network with the payers, and the payers are stating that their panel is closed, which effectively means you can't have the practice or a particular provider credentialed with that payer. I've seen this more and more recently with specialty providers, specifically in the podiatry and urgent care space. On that same vein, we have seen the group credentialed, but new providers coming in not able to get in panel. The payer simply feels they have enough providers in that specialty and don't want to add any more. And there's really little that can be done. And we're seeing more of that in the commercial payer mix because they're trying to control costs. The concern of whether or not a provider can be credentialed is exacerbated by how dynamic the provider landscape is today. This has been going on since early in COVID, but we are seeing providers joining new practices with an existing patient base. And when that happens, you need to ensure they don't lose those patients by being out of network. When a provider moves from one practice to another, we already estimate that they may lose about 50% of that patient base. So to keep the 50% that you really need to stay, you want to ensure that they're still able to see that patient's insurance. And also part of the change in the payer landscape in small practices is that we are starting to see an expansion into new clinical staff by adding nurse practitioners, which has been going on for a while, but now we're seeing the fold in of nutritionists, physical therapists, counselors to address their patient needs. It is actually a great idea, but this also means that those providers need to be credentialed, and it also may mean that you need to take a look at your payer mix because you may need to fold in new payers that you hadn't historically taken, because they are specific to that specialty, like physical therapy, or you need to augment your payers to fill their schedule. Another change in the provider landscape is the expansion of private equity into the small business marketplace. They're able to partner with practices to expand and increase their services, but that often means you get assigned a new tax ID, and then if that happens, you have to get re-credentialed on everything. So that takes a lot of work. So when we're talking about a lot of work, let's talk about administrative burden. I'm not going to spend a lot of time on this because it is not new, although I do feel like it is changing. For example, the No Surprises Act that began in January requires practices do more to address patient responsibility, which is taking away from revenue generating clinic time. The No Surprises Act specifically addresses notification of patients that are out of network prior to the service being rendered and a good faith estimate provided to that patient of their responsibility. This is a huge administrative burden for practices to take on. So again, having them in network can sort of alleviate some of that burden. And of course, I'd be remiss if I didn't comment on the patient as a consumer. Patients are finding their way to doctors through a digital footprint. It drives new patients to your practice, and then having a patient-centric model of practice will keep those patients in your door. But this only works if you're credentialed with the payers in your area and credentialed with the payers that your referring physicians are also taking. Patients now approach healthcare with a consumer mindset and are expecting services like telehealth, personalized medicine, self-service technology. Patients are significantly less likely to see a provider that is out of network because in this digital age, they'll be able to find a provider that takes their insurance and offers those new services as well. So let's talk about inflation. We know that COVID has created an increase in the cost of doing business, but that is compounded by the actual market being driven up by inflation. So our cost of doing business is significantly higher. And it has also eroded employee loyalty. Employees are leaving practices to go to other practices. They can make more money, or they're leaving the medical industry altogether. This can have a huge impact on credentialing. If you're managing your credentialing in-house and you have employees doing it, if they leave, you could be creating an intellectual property desert for that. And if you replace that employee, you need to replace them with somebody who understands the process end to end. And that will take a higher skilled employee, which will be more expensive and often harder to find in today's market. So the last thing I just want to touch on, and these are just the top major changes in the market. I could probably have a list of 30 here, as I'm sure we all know. But I think another recent change I've seen in practices is doing more retail work. Now, traditionally, retailers' work has been sort of cash and carry. I have all kinds of fancy creams in my office. You buy it, you walk away with it. Or Botox, or, our podiatrists do a lot of, over-the-counter shoe inserts or diabetic shoes, things like that. That is true retail work. But also what we're seeing is practices going in to providing sort of what they would consider retail, but those items are actually fall under the umbrella of DME, or durable medical equipment. If you're issuing DME, you need to ensure that you are credentialed with DMERC. It is very separate and distinct from Medicare, but you do not want to be sending DME claims to Medicare. They will not pay them, right? And so you need to make sure that you are credentialed with DMERC. So how does the change in landscape and the change in market play a role in credentialing? By far, the biggest challenge I see constantly with my revenue cycle management clients is a new provider starts seeing patients prior to that provider being credentialed. You should always set the expectation with a new provider when you're interviewing them that they will start when the majority of their the payers in your your network are credentialed, right? That should be contingent on their start date. If certain payers take too long and it's just a handful that are still in process, make sure that that new provider is not seeing those patients. Maybe they get seen by one of your partners, but you cannot be guaranteed that they are going to backdate your credentialing to the time of application or to the time they received it. Now, there are some payers that we know, have more flexibility like Medicare, but make sure your new providers are not starting until you're credentialed. Another consideration is if a new provider has never been credentialed before, let's say they're out of residency or they're new to your state, so now they have to get a new state license, it is going to take their process significantly longer than a provider that's been in network, with your payers for years. They're joining your practice from across town. So those need to be tied to your group tax ID and MPI. That is a simpler process and takes less time. The second key factor you should look at is denial trends. Your biller should be on the lookout for any denials related to what we would call provider relations or credentialing. This is not just an issue when you onboard a new doctor, but is a concern for existing providers. If you're not having someone sending your updated license, updated CME credits, or updated malpractice insurance, you will lose your current good standing with the payer. I can't tell you how often we have to inform a client that they're getting denials for credentialing, and they tell me, my credentialing company deals with it, except the credentialing company dealt with getting them credentialed, but they are not keeping up with their expirables or re-credentialing. Denise is going to go into this in more detail on the re-credentialing, but generally re-credentialing is done every 2 to 3 years, but expirables will likely come up during that cycle. So you could get credentialed today, or let's say 2 years ago with Blue Cross, you don't have to be re-credentialed until 2024, but your license came up last year, you will lose credentialing for not sending your updated license during those mid-cycle times. And then you have to go through the process all over again. So the one thing we never want to do is tell a patient we're not taking your insurance. Once a patient goes somewhere else, they are likely not going to come back when you are credentialed. Again, the patient is a consumer now, and they don't necessarily have that historical commitment to a practice or a provider that we saw in the past. My parents will go to their, providers that they've been seeing for years, and even if they're not happy, their answer to me is, "Oh, well, that's my doctor." Whereas me as a consumer, if I'm not happy, I'm finding another doctor, right? So once I go and find a doctor, if you call me back and say, "Well, we can see you now, Dr. Smith is in network," I'm likely going to have said, "Well, I've already addressed my problem." So I've already mentioned the No Surprises Act as a specific regulation that can impact your practice, and certainly your credentialing status will impact what you do with those patients. But that's not the only regulation that I want to bring up. One of the big concerns when you're talking about credentialing and whether or not you can see patients is often providers feel like they can co-sign a note and be listed as the rendering provider on a claim, and the non-credentialed provider be listed as the servicing provider. This is known as incident to billing, except there are significant rules to this. The most important key to incident to billing is that, number one, is you cannot do this for providers of what we call like licenses. So a doctor can't do this for another doctor, a DPM can't do this for a DPM, or a nurse practitioner cannot do it for a PA. The other key requirement is that the servicing provider must be following an existing care plan. Therefore, they cannot be doing this for new patients or existing patients being seen for a new problem. Also, the rendering provider is required to be on site while that service is being rendered by the other provider. Payers are requesting medical records for a myriad of reasons in today's market. And they'll be able to catch that you are not following Incident 2 guidelines very quickly. And this is a hot button issue that they're looking at. So make sure if somebody is not credentialed, like a nurse practitioner, it's fine if your doctor is the rendering provider if they're following those other rules. So to wrap up the market insights, one of the ongoing problems the small market faces is that that payers are lowballing you compared to enterprise groups that can have more leveraging power, buying power. There are ways to address this with sending the payers your performance data, maybe your readmission rates, things like that. And oftentimes a third-party credentialing service can help you do that on your behalf. And that will help sort of, increase your fees for these commercial payers. And with that, I think I've taken enough of Denise's time that I'll turn it over to you, Denise, for the ins and outs of credentialing.
Okay, well, thank you, Christine. So now we're going to go from California to Tennessee, and we're going to talk about how do the providers get to see the patients they want. The life cycle of a provider rests on enrollment, credentialing, hospital privileges, and PAR and non-PAR analysis, just to mention a few. Let's dive a little deeper into exactly what that means. So we all know that executing a consistent and reliable enrollment program is not easy. The volume and variety of information payers need makes this a detail-intensive job that is easily thrown off track, especially for smaller practices that don't have the luxury of allocating full-time resources to the enrollment effort. Your providers need to be billable, and until enrollment with payers is complete, they aren't. Enrollment means that your provider is on the approved payer list. Credentialing in healthcare is the process by which we prove that physicians have the education, training, and skills to properly care for the patient. Healthcare oversight organizations monitor the work of medical providers to evaluate, among other matters, reports of improper care. All of this reporting and monitoring must be continually checked by healthcare facilities that employ providers and by health insurance companies that want to issue the approved provider list. This process requires significant work and effort to satisfy multiple entities across multiple states that regulate standards for credentialing of providers. Do you know all the payers your providers participate with? A PAR and non-PAR analysis is critically important in that it allows you to create a baseline of who your providers are enrolled with. The simplest way is to request rosters from your insurance plans. You should ask them for the participating enrollment data that they have for all of your providers, locations, tax IDs, specialties, and taxonomy codes. Once mismatches are identified, initiate enrolling or linking your providers to the missing locations or tax IDs. Many plans require patients to receive services only from participating providers. If the provider is non-PAR, part or all of that claim may be denied, or at best, the reimbursement could be drastically reduced. A benchmark example that I found interesting to try to figure out how many pins that you should be keeping up with is if you have, you take your total providers, multiply that times the total plans, multiply that times the total locations. So if you have 5 providers and they participate with 25 plans and you have 3 locations, then you're looking at an opportunity of having to track 375 different pins. I thought that was real interesting. Quarterly is a good timeline to conduct a PAR non-PAR analysis because you could be losing revenue and causing patient dissatisfaction. Do your providers see patients in the hospital? Hospital privileging is the process whereby a provider is authorized to perform a specific set of patient care services based on an evaluation of the provider's credentials and performance. Now, this benefit is not available to all healthcare providers. Your credentialing vendor should prepare the applications for your review and approval. This includes completion of the application as well as providing the required documents for the hospital to process the application and working with the hospital representative to meet their specific institution's requirements. Once privileging has been approved, your credentialing vendor should maintain re-privileging as requested by the hospital. Primary source verification is required if you're confirming that an individual possesses a license, certification, or registration to practice a profession in that state. To meet primary source verification requirements, the documentation must come directly from the entity that was issuing the license, certification, or registration. Primary source verification is always required to obtain license from any state or upon any entity's request. Does your current credentialing vendor perform fee schedule reviews during the re-credentialing process and as needed? They should have a copy of your contracts and a list of the CPT codes utilized by the providers to run a comparison analysis. If your fee schedules don't meet the current market analysis, then the payer should be contacted and a request made to increase your fee schedule. We've been talking about credentialing, and this graphical representation will reflect multiple pieces that revolve around the complex process. It all begins with determining the payers your provider wants to participate with. Consider the top reimbursement payers in your area. Applications must be completed and audited for accuracy prior to submitting to the payers for review and approval. If this is an initial application, primary source verification may be required. Payers will sometimes close their panels if they feel there are enough providers participating in that area, and then they can reopen them at a later date when the need arises. During the credentialing timeline, which ranges anywhere from 45 to 180 days, timely follow-up on the status is critical because credentialing is at a standstill until any additional information requested is received by the payer. Tracking the follow-up on the status is key. Does your credentialing or ongoing re-credentialing vendor use a spreadsheet that requires someone to remember to check it, or do they use software-generated work lists that monitors the deadlines and renewal dates? Once the enrollment is processed and the payer approves participation, how quickly is your provider notified so they can begin providing care for patients and receive optimal reimbursement for it? I mentioned the credentialing process can take anywhere from 45 to 180 days, during which incident to billing may not be an option. Christine touched on this earlier, but I want to remind you that there's only two circumstances allowed for incident to billing. One, you have a mid-level provider who can bill under the MD license if there's an existing care plan on that patient and the MD is on site at the time the services were rendered. And two, if the provider is filling in for another practitioner that is out, on leave, on vacation, and this is known as locum tenens. Christine mentioned earlier that patients are consumer-minded, directly involved with their care, and have more choices than ever before. They expect high-quality yet affordable health care. As we transition from fee-for-service to fee-for-value health care, we must utilize a credentialing resource that has broad spectrum knowledge, experience with standards fixed by state, regulatory bodies, and accrediting organizations. How do the providers keep the patients that they have? Did you know that different payers have different requirements? As example, if the provider wants to bill under his or her NPI or Social Security number, then the provider only needs to be enrolled. If the provider wants to bill under the clinic's tax ID for Medicare and Medicaid, the company and the provider have to be enrolled individually first, then the provider has to be linked to the clinic. Commercial payers require only the provider to be enrolled and add the clinic's detail in the application to get a group contract to bill claims under the clinic's tax ID number. There are a few payers where the clinic is required to have a minimum number of providers, like 2 or 3, to do that. Does your current credentialing vendor have a standardized and documented QA process? Credentialing and provider enrollment is becoming more complicated and time-consuming as technology advances and additional services are added. Is there someone other than the person who completed the applications or forms reviewing them for accuracy and completeness prior to them being submitted to the payer. Lengthy credentialing procedures and delays prohibit providers from being reimbursed by the payer for seeing patients that have that insurance. A provider's time is money. Some suggestions to avoid delays are continually move the process forward. Ensure the information is correct with all the requested details. Understand credentialing a provider and establishing a provider contract with a payer are two different matters. Credentialing happens first, then the payer and provider agree on the contract. Start the credentialing process as soon as possible, long before the provider is expected to report for work or begins billing a specific insurance company for treating patients. Make the provider's start date contingent on his or her submission of all required credentialing information. Conduct a background check. Investigate malpractice claims against a provider. Understand the state's regulations related to credentialing, and use software to help organize and track the process. Does your credentialing vendor use or meet benchmarks? Here are some vital metrics to help evaluate the credentialing process. Total days in enrollment. How many days does it take to enroll a provider? Applications processing time. How long does it take to submit all necessary applications upon receiving the required information? Enrollment denial percentage. How many claims are currently being denied due to enrollment issues? Days in signature stage. How long does it take to obtain a signature? Does the vendor understand fee schedules and what percentage of Medicare you can expect from the major payers in your area? And what payers matter most when contracting in your area? Technology is vital in today's healthcare climate if you want the process to be smooth and efficient. Relying on Excel spreadsheets or doing everything manually is inadequate in most cases and will result in a fragmented process with you paying more in both time and money. Does your credentialing vendor utilize software for system-generated alerts, reminders, and work lists? So what is next in refining procedures regarding credentialing and re-credentialing? Key pieces of information in a matrix is essential and can become the central knowledge base of any front desk, clinical, or revenue cycle department. It is a resource that will serve many operational purposes and ensure that organizational knowledge is well distributed without being lost. A comprehensive matrix will not only be an information hub, but also an important training and onboarding tool. When properly built, both new and current employees will have all the information at their fingertips. Some of the key pieces that should be included in a matrix are general payer information like the contract start and stop dates, payer contact information, phone number, website, URL, claim address, fax numbers, rate information by service, that's really important, payment methodology and billing codes. Billing operations is another consideration. How do you send in the claims, post, receive claim payment? What about the timely filing guidelines, payment timelines, and then common processing issues, tips and tricks to better understand the payer? And we can't forget about authorization and eligibility operations. What are the authorization requirements? What's the method to request authorization and eligibility? What about retro authorization guidelines or services that are just not authorized? A well-run matrix remains accurate as new information is identified and contracts are updated. Updates will come from a variety of sources, and a formal process will help you with organizing the incoming information to ensure that nothing is missed. For optimal reimbursement, do you know the payers in your area with the highest reimbursement rates? Are your providers credentialed and enrolled with them? Credentialing isn't a one and done process. The pre-credentialing timeline is typically 2 to 3 years, depending on the payer and entity. As example, your providers could be credentialed until 2025, but if you have a couple of those that has something that expires in 2024, if those aren't updated with the payers, then your provider won't be in a good standing. They could be considered non-par and claims could be denied. Does your current credentialing process have the bandwidth to keep the process moving forward without any lapse in participation? Who at your practice reviews the denials for not in network? What percentage of claim denials are due to credentialing or re-credentialing issues? Do your providers round on their patients that are hospitalized? Do they have privileges at that hospital? Are all payer fee schedules loaded in the software so during payment posting, reimbursement can be verified for accuracy? In summary, we would like to partner with you to help navigate the complex road to credentialing, recredentialing, source verification, hospital privileging, and fee schedule review. These services are available to both current NextGen clients and others a la carte or individually based on the practice's need. We encourage you and your organization to streamline and consider these strategies to ensure your revenue cycle is primed for success. Please feel free to reach out to Christine or I if you would like additional details regarding your services. Thank you for your time today, and with that, we'll open up for questions, and I'll turn it back over to Christine.
Chris, do we have any questions in the QA?
We do. We have just one right now, unless anyone, we still have time, but if someone wants to put another question out there, or something comes up. But what about a well visit? How are those handled?
That is absolutely dependent on your credentialing. Certainly, Denise, you could probably speak more to this, but Medicare pays for a annual wellness visit. And so if you are taking Medicare patients, that's an expectation of a service that can be rendered, on Medicare patients annually. It certainly depends on whether or not the payer will pay for those services. Sometimes it may not be as much around credentialing and whether or not the payer has that as part of their benefit plan. It can also be specific to, like an employer-sponsored plan. For instance, I have Blue Cross Blue Shield of California through NextGen. It could be that my plan with Blue Cross Blue Shield doesn't cover annual wellness visits. That's why even if you are credentialed, it doesn't absolve us from checking eligibility, and within the eligibility, checking patient benefits, and confirming that if the service you're rendering is going to be covered.
And another thing, I'm sorry, go ahead, Christine.
Sorry, I was just I think it's a continuation of that, but for incident to billing and also is supervising provider relevant was kind of a follow-up.
Well, first, Denise, do you want to add something before you move on from the annual wellness?
I did. I just wanted to say that your credentialing provider could be helpful with the annual wellness visits because there are multiple pieces to that. And for an example, your credentialing provider could help like with the marketing piece where they can, get in touch with the patients and get them to schedule the visit. And then they also can do the piece of the health risk assessment, which, requires time if the patient's in the office. Your credentialing provider did that. Then when the patient shows up in the office, that gives the provider more time with that patient, and they actually could do more annual wellness visits in a course of a day's schedule. So I just wanted to add that. Go ahead, Christine.
Yeah, and then Chris, I'm sorry, could you ask the question again about incident to billing?
Yeah, incident to billing, and then also is supervising provider relevant?
So supervising provider, generally when you're doing incident to billing, you have a rendering provider who is overseeing that patient's care plan, and that's listed on the claim as a rendering provider. And then the servicing provider is the person that's actually in the clinic. So with the example of I'm a physician and I have a nurse practitioner. The nurse practitioner is seeing, patients in follow-up for an existing care plan. I sign those notes. I'm on site while I'm seeing it. I would be the rendering provider, not necessarily the supervising provider when it comes to submitting claims.
Okay, and then do well visits fall under the incident to criteria?
Yes, it could fall under the incident to. Well, I should say certain parts of the annual wellness exam do not need to be rendered by a physician. They can be rendered by ancillary clinical staff, like a nurse.
Okay, and this is the last question we have time for. Are you seeing commercial payers requiring mid-level providers to be credentialed?
it's kind of a mixed bag. I would say it is occurring more and more that the mid-levels do have to be credentialed. I know that, historically, Cigna has not required mid-levels to be credentialed, but, that is something that you have to keep up on. That's part of those change in the payer landscape, change in regulations, is that all of a sudden you'll get denials for not being credentialed, and you'll find that, well, it's because we've never had to credential our mid-levels. And I think, again, Cigna is that specific payer that we know has made that recent change. Always, when you're doing your re-credentialing or credentialing, make sure you document that with the payer, that as of this date, you don't need it credentialed. And then that's one reason why it's so important to check denials. If you're seeing denials for all of a sudden, your nurse practitioner or your PA, or other types of mid-levels are getting denials, and they're the servicing provider, or the rendering provider, that they've changed their rules. But I would absolutely make sure you're reaching out to your payers and documenting that.
Great. All right. Well, thank you, Christine. Thank you, Denise, for your time today. Thank you for talking us through this credentialing journey. And thank you, everyone who attended, for what you guys do in your communities and how you help everyone on their wellness journey. We will send a copy of this out in a few days, and any follow-up questions we'll get to directly that weren't answered today. So again, thanks, Christine, thanks, Denise, and everybody have a great day.
Thank you for having us.
Bye-bye.